Hello everyone, welcome back. Today we'll discuss neurology for PLAB 1. First most important concept is the differentiation between upper motor neuron lesion and lower motor neuron lesion. Examiner will give you a question in PLAB 1 because the lesion or location of lesion or finding out where the location of lesion is important for a junior doctor working in NHS. Upper motor neuron lesion, usually the signs are increased tone, increased reflexes, that is hyperreflexia with upgoing plantars. In the exam, the examiner can tell you that there is Babinski sign that is positive, which indicates that the lesion is an upper motor neuron lesion. In general, talking about upper motor neuron lesion and lower motor neuron lesion, the upper motor neuron lesion is the lesion anywhere up to the anterior horn. The lesion present, which is present after the anterior horn cell, is basically a lower motor neuron lesion. And in lower motor neuron lesion, the clinical signs are hypotonia. There will be significant muscle wasting with fasciculations that are usually seen. And the plantars can be mute or can be downgoing in lower motor neuron lesions. One most important question the examiner can ask you is about vitamin B12 deficiency, where there can be mixed signs with the loss of proprioception and vibration that points towards vitamin B12 deficiency. Sometimes upper motor neuron lesions signs and lower motor neuron lesion signs can coexist in B12 deficiency. The examiner can also talk about a middle-aged guy who has got both spasticity or upper motor neuron signs in the lower limbs and low motor neuron signs in the upper limbs, which points towards amyotrophic lateral sclerosis. That is a type of motor neuron disease. And the examiner can indirectly ask you what is the treatment or what is the next best step in the management of this patient. You will have to first make sure that you need to confirm the diagnosis. So please do select the nerve conduction studies as one of the most important things for diagnosis of motor neuron disease. It is the nerve conduction studies or electromyography. You will find an option of NCS or EMG. This is one thing you will have to see. Remember, it is the electromyography that is diagnosis of motor neuron disease. Most of the patients in the clinical settings are usually diagnosed by the clinical examination. So please do bear in mind that motor neuron disease, there will be one question in PLAB 1. Talking about the treatment of motor neuron disease, it is the riluzole that is usually asked in the question. Next, talking about the signs of upper motor neuron lesion and lower motor neuron lesion. As discussed, I want you to understand that hypertonia with increased reflexes is upper motor neuron sign, and hypotonia with decreased reflexes is lower motor neuron sign. There can be wasting that is most significantly seen in the lower motor neuron lesion compared to an upper motor neuron lesion. All right. Next, we talk about the sensory deficits. We all know that the pathways that carry the temperature and pain is spinothalamic pathway. Whenever a spinothalamic pathway is affected, it usually results in the contralateral loss of pain and temperature. Nothing but the pain and temperature are lost onto the opposite side. Whereas talking about the dorsal column tracts, which usually carries vibration and position sensation, it usually is affected on the same side if dorsal column tracts are affected. Remember, ipsilateral loss of vibration and proprioception or position can be seen in dorsal column tract lesion. How do you differentiate a cortical lesion from the spinal lesion? Remember, spinal cord maintains adult dignity. That is, the spinal cord maintains or gives you the opportunity to maintain your bowel, bladder, and sexual function. Whenever there is spinal cord that is affected, it usually causes bowel incontinence, water incontinence, or loss of sexual function. When these three findings are present in the question, you will have to think that the lesion is in the spinal cord. How do you differentiate the cortical lesions and the things that are affecting the spinal cord? It is usually the sensory involvement that is usually seen in the cortical lesion. All right. Next, we talk about the grading of muscle power. Whenever you are trying to grade muscle power, please ask the patient to lift the limb. If he is able to lift the limb on his own, it is 3. The grading is 3. If he is able to resist forcefully, it is 5. That is very important, please. All right. Next, we talk about the peripheral nerve roots of the upper limb. Obviously, C5, C6 usually supplies deltoid and biceps. Biceps reflex is tested and it indicates the function or intactness of C5, C6. Talking about the triceps reflex, it is C7. Talking about the finger extension, it is C7 and C8. Talking about introrsi and lumbricals, or famously in the exam, the examiner will tell you that the finger movements or fine finger movements are usually controlled by ulnar nerve. The nerve roots are C8 and T1. Next, we talk about the peripheral nerve roots in the lower limb. These are some of the important peripheral nerve roots I want you to remember. L2, L3, L4 is a femoral nerve root which usually supplies quadriceps and is helpful in the knee extension. Tibialis anterior is usually supplied by L4 and L5 which helps in the dorsiflexion. Gluteus medius is usually L5 and S1 and gastrocnemius which helps in the plantar flexion is S1 and S2. Talking about the dermatomes, I want you to understand that the dermatomes usually supplying the upper limbs are C6, C7 and C8. Remember, it is the thumb that supplies the C6, middle finger indicates C7, little finger indicates C8. Nipple is T4, umbilicus is T10. Inguinal ligament which starts with I, that is 1, that is L1 is inguinal ligament. L5 usually, big toe usually represents L5. The lateral foot usually represents the S1 dermatome, and in the perineum, this is important, it is usually S2, S3 and S4. This is a picture of dermatome where you will find that C2, C3, C4 is usually supplied by to the neck, and C5, C6, C7, C8 is to the upper limbs. T4 is at the nipple level, T10 is at the umbilicus level. Next, we talk about the cerebral blood supply. I want you to understand or remember three most important blood supplies. That is the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. No wonder the examiner can ask you the questions around these arteries, mentioning that the patient has got lower limb weakness, which indicates that there is a infarct or a pathology in anterior cerebral arteries. Please do remember for lifetime, whenever there is anterior cerebral artery that is involved, it is usually the contralateral leg weakness that is usually affected. Whereas if middle cerebral artery is affected, whenever there is middle cerebral artery that is affected, it is the contralateral phase and the arm that is mostly involved rather than the leg weakness. So the patient usually presents with the right arm weakness with face weakness if there is middle cerebral artery involved. Posterior cerebral artery, it is usually the contralateral hemianopia or famously the eye signs that are usually seen in posterior cerebral artery occlusion. I also want you to remember that there is a question in PLAB 1 mentioning that the patient is not able to move the upper limbs and lower limbs, patient is bedridden, but patient is able to follow the commands through the eyes and is able to follow the eye movements or finger movements. It is called as locked in syndrome where your hands and legs are locked but your eyes are intact. The eye movements are intact. This is called as locked in syndrome and it is usually because of the lesion at the basilar artery or occlusion at the basilar artery. This is one thing the examiner can ask you. You can see that there is the anterior communicating artery. Please do remember that after this session, whenever you remember anterior cerebral artery, it is the lower limbs that are affected. If it is the middle cerebral artery that is affected, it is usually the contralateral hemiparesis with the facial involvement. If it is the posterior cerebral artery, it is the eyes that are involved. The famous syndrome called Anton syndrome, where there is posterior ischemia of the occipital lobe, ischemia of the occipital lobe, where the patient tends that he is able to see, but he is not able to see. He's got the visual stimulus, but the visual stimulus is not going and stimulating the visual cortex. So the patient is blind, but the patient denies it. This is called as Anton syndrome, please. It is also called as cortical blindness. Famous question usually asked, which artery is involved? It is the posterior cerebral artery that is involved. Next, we talk about some of the special syndromes where the examiner can tell you that the patient has got arm claudication or arm pain on repeating activity whenever the patient is able to lift the arm above the shoulder. This causes pain, this causes brainstem ischemia, and this causes vertigo when the patient is involving the arm or whenever the patient is working with the arm that is affected. This is classical example of subclavian steal syndrome, and you will get a question on this in PLAB 1. Superior cerebellar artery, whenever it is involved, patient usually presents with vertigo or dizziness. If there is anterior inferior cerebellar artery, it is the vertigo and hearing loss that you will have to think of. Please do remember that the location of vertigo and hearing loss is anterior inferior cerebellar artery. Talking about another patient where the examiner mentions that the patient complains of vertigo, difficulty swallowing, and speech problems, it is the posterior inferior cerebellar artery. It is the pica artery that is usually involved when the patient has got symptoms of vertigo, dysphagia, and also involvement of the speech. Thank you very much. I'll see you in the next session with headaches.